Now it's my delightful privilege to introduce Dr. Morie Gertz, who will be presenting on WM 101. All aboard. Dr. Gertz has been a long-time standing partner and friend of the IWMF. He's on our Scientific Advisory Committee, and he's been there forever, and he has helped the IWMF out for years. We haven't heard from him for a couple of years. So, Morie, thank you for coming and giving this effort.
My pleasure. Thank you. So my task is to kind of do the Waldenström 101, so you have some conceptual framework to understand the disease. Since I will not be using slides, I can have the house lights up. So we're going to get started right now, and I'm going to provide you with a metaphor as to how you conceptualize this disease. So we're going to start right off. Oh, perfect. Thank you. That's beautiful. So what you're looking at here is a soup bone. So you go to Winn-Dixie, and you're making soup stock, and you buy this soup bone. And you see the soup bone has two separate parts to it. There's a thick outer white hard shell, and that makes the bone extremely strong. So you can't break it even if you stomp on it. But in the center of this soup bone, there's this brown spongy area within the bone, which we refer to as marrow within the bone, and it flavors your soup because it's extremely rich in fat. There's a very high fat content in marrow. You can make the lights higher. And, but when you see it in the store, it's kind of a brownish, dark brownish, spongy. In a freshly slaughtered animal, that's not how it is. In a freshly slaughtered animal, it's bright red. It's the color of blood because that's the garden with which all of your blood is produced, within that marrow garden. And when you look microscopically into this garden, you'll find that there are three main crops. And when I say crops, the marrow functions, the garden functions. There are seeds. The seeds give rise to plants. The plants give rise to fruit. And the fruit are the mature circulating blood cells that you have. And when you look at the composition of this garden, what you find is that approximately 60% of that acreage is given over to the production of white blood cells. Those are the cells that help you fight off infection, they get rid of bacteria, they cleanse wounds, they're their healing cells. 10% of the garden acreage is a second crop given over to the clotting of the blood. That clotting of the blood is referred to as platelets, but that basically clots your blood. 20% of the garden acreage is given over to the production of red blood cells. Those, of course, are the cells that color your blood red, but they're responsible for carrying oxygen to your tissues. Oxygen is needed for combustion to produce energy in your muscles. And if you don't have enough red blood cells, the technical term for that is being anemic. You have low red blood cells, you're anemic. Those of you who are my age recognize the Geritol commercials where you have iron poor, tired blood. It really is not enough blood, not enough hemoglobin. If you don't have enough hemoglobin, depending on the severity, what you'll notice is perhaps you'll do fine if you're sitting in a chair at rest. But as you get progressively anemic, all of a sudden, climbing that flight of stairs becomes a bit more of a challenge than it used to be, or walking up a steep incline or carrying shopping bags becomes quite a bit more challenging, because when you have low red blood cells, low oxygen carrying cells, the only way to deliver enough oxygen to your tissues, if you have less red blood cells, is your heart has to work harder to pump more blood, since there's less oxygen carrying capacity. Your heart has to work harder. So as you exert, your heart starts to beat faster, and it starts to beat harder. And so climbing that flight of stairs, you might notice that rapidity or the intensity of the beating due to a reduction in these red blood cells. Now, those of you who are math geniuses recognize that 60 plus 10 plus 20 adds up to 90. So we haven't quite accounted for the entire garden composition. And in fact, the garden has these three main crops, but there are actually a whole host of small boutique crops that grow within that garden, comprising that final 10%. And the majority of those cells are of no importance to our discussion today. Eosinophils, basophils, macrophages, unimportant. But when we look at the garden, here we go. Sometimes something goes haywire with the components of that remaining 10%. And the cells that I'm talking about now are called lymphocytes or lymphoplasmacytes. Name's not critically important, but what will happen, as is typical for all forms of cancer, is they will change genetically. They will become damaged and they will acquire a genetic mutation that gives them a growth advantage. And so these cells, which occurs in about 5 people per million per year, these cells start to grow within the garden. And I'm drawing them there. And of course, when we have unwanted growth in our garden, we've got our crops that are growing, but now we're starting to see these unwanted plants grow. We refer to those as, so that's our weeds, and these weeds being our unwanted cells. And in this case, these cells are lymphoplasmacytic cells. These are the cells of Waldenström's, and the weeds are growing in the garden. Now, at a certain point, those weeds will grow to the point that they'll start to choke off the garden, so that the weeds start to interfere with the normal function of the seeds and the plants and the fruit. And they interfere, and so the normal cellular components, the 60-20-10, start to be impacted. But the normal plants in the garden are not all equally sensitive to these weeds. The red cells are much more sensitive than the other components. The cells that carry oxygen, the cells that are measured by your hemoglobin level in the blood. If you don't have enough, is anemia. As these weeds grow, they'll selectively choke off the production of red blood cells, and you will become anemic. So the primary manifestation in the majority of patients, I'll talk about other things in a bit, is that these weeds are killing off the red cell plants, resulting in anemia, which you're manifesting as fatigue, shortness of breath, no stamina, you wake up tired, you go to bed tired. And that actually sounds like a regular work day for me, but it begins to interfere. Now, there are some patients who have relatively small or moderate numbers of weeds in their garden, and those weeds aren't interfering with the garden function. They're there, but they're not causing any problems. So they're incidental, they're there, but the garden is working perfectly well. Now, if I had a weed killer that would permanently eradicate those weeds, I'd give you the weed killer, the weeds would be gone, you'd never have to see me again, and you'd go on with your life. Regrettably, I don't have that weed killer that will destroy each and every weed to never come back. As a consequence, there are circumstances where we'll find weeds in the garden and it's causing no problem, and we'll say, you know what? The weeds are there, but they're not really causing a problem, and since I can't cure them and you feel great and I can monitor you, we're going to watch and wait those weeds until such time, if such time occurs, they get to the point where they start interfering with the garden. Now, when specialists talk to each other, we have to have certain established definitions so we can communicate. So when there's weeds in the garden that aren't interfering and causing no symptoms, but the acreage that's involved in the garden exceeds 10% of the garden acreage, we'll refer to that as smoldering macroglobulinemia. We're not treating it because it's smoldering. It's over 10%, but that's a classic watch and wait. Typically, if the percentage of weeds in the garden is less than 10%, then we would refer to this as IgM-MGUS, because there are some weeds there, they're small, the risk of it causing a problem isn't very great, and so we will recommend no interference. Now, this is an important concept to get straight, because I see a woman, I do a screening mammogram, we find a lump on the mammogram, she's completely without symptoms. I don't say, well, it's not bothering you, go, I'll check you again in a year. What's the key distinguishing feature about why I'm telling this patient with weeds in the garden that we're going to do nothing, but I see the woman with an abnormal mammogram, or alternatively, I do a colonoscopy, I find a lump in the colon, but the patient has no symptoms. I'm not saying, oh, well, it's not bothering you and it's not bleeding, so we're just going to watch that colon mass. What's the fundamental distinction that leads to the different approaches? Anybody? Say what? Cure. That's right. So whoever said cure, 10% off on your next registration. It's cure. That's the key. So if you do the lumpectomy or you do the colon resection, it's cured, goodbye, it's done. I can't say the same thing about the weeds. And so if I can't cure it, functional is different, but if I can't cure it, then we want to be sure we have you at optimal quality of life and activities of daily living. But if this was incidentally detected, then you're by definition without symptoms. So I've got nothing to make you better, so we're going to monitor. And there's your fundamental difference about why did my doctor tell me I had cancer, and then we're going to do nothing about it. It's that inability to cure and the fact that it's not symptomatic and can, in many instances, be so pokey that it could be a decade or more, maybe never, before the weeds get to the point that they cause symptoms. Then the question comes up, how did the doctor even figure this out in the first place? And that goes to the second piece here, and that is that these weeds are unique among all of the garden components of that bone marrow garden. These weeds have the unique ability to make a protein that you can measure in the blood. That's different from other types of garden weed problems. And of course, that protein that these weeds make is the IgM protein, the macroglobulin. Only these cells, no other cells will make this protein. So it's quite specific. And in fact, IgM was the very first tumor marker. It goes back to 1948, when the protein, which is, as proteins go, it's enormous in size. It's humongous, which is why it's a macroglobulin, was first recognized in the blood of patients with this. And of course, it was recognized by the Swedish physician Jan Waldenström. So it's kind of a no-brainer what we're going to end up calling this. And so this IgM protein becomes a very effective indicator of what's going on in the garden, because the amount of protein in a given patient is direct measurement of how many weeds there are. Now, everybody's weeds make a different amount of this protein. So sitting around at breakfast saying, my IgM's 500 and mine's 1200 and mine's 2200 has no valid meaning at all, because different people make different amounts of protein. But what your protein does over time, that's a big deal. So if you're being monitored, either off of therapy or never been treated, a stable protein over time would indicate that the weeds are probably not doing very much. If you're receiving weed killer and you're killing the weeds, the expectation is, well, if the weeds are the only source of this protein, and we're killing those weeds with weed killer, that protein should be going down. And that is exactly what we see in practice. And if you've been treated or never been treated and we see the protein going up, our inference is that the number of weeds in the garden are growing, and that is the wrong direction, and that's a bit of an ominous sign, indicating that for the untreated patient, you might need treatment sooner rather than later. And in the previously treated patient, it may be an indication that you're going to need treatment again. Now, the presence of that protein is a big deal because, as has been mentioned, this is a type of lymphoma. Those weeds in the garden are referred to as lymphoplasmacytic cells, and this is a lymphoplasmacytic lymphoma. That name is actually not important. They're weeds. But there are patients who have lymphoma in the bone marrow, and there is no protein marker to measure, and those poor patients end up getting bone marrow after bone marrow after bone marrow. As is the case with most patients who have leukemia, they have to have repeated bone marrows in order to assess the disease, which is generally not required in patients who have macroglobulinemia, because the protein is such a good surrogate marker. And of course, if you think about it, there's your soup bone, there's the thick outer white hard shell, and I'm assuming everyone in this room has been on their stomach while a needle goes through, like that, through that thick white shell, to take a sample of that so we can count the percentage of weeds in the garden. And that's generally not necessary because we have the fortune, if you will, to be able to measure the protein as a surrogate. But keep in mind, the disease is the weeds. It's the weeds that are the problem because they're choking off the garden. The protein is generally not the problem. The protein's a marker of what's going on, but the protein in the majority of patients, few exceptions I'll get to, is not the problem. It's a way in which we can quantify and indirectly measure the number of weeds in the garden, but it's the weeds that are the problem, and we're using the IgM just to know what the weeds are doing, up, down, the same. But like everything else in medicine, there's exceptions. with regard to the protein itself not being the problem. The majority of patients, it's the weeds that are the problem. They're anemic. Sometimes the blood platelets will go down. These weeds will grow in lymph glands. So some patients may feel a lymph gland in their neck, maybe under the armpits or in the groin. Those usually don't cause symptoms, but they're good markers kind of to know what's going on. They don't always require treatment, but they're just things that sometimes patients can refer to just know about their disease activity. But as I said, this protein is really big. And that size has an effect because when you think about your blood circulating through the blood vessels, what ends up happening is your heart, which is basically a piston, is pushing the blood through the blood vessels. And the blood itself is basically water. It's plasma. And suspended in the plasma are all the different blood cells circulating through. And plasma itself is pretty watery. If you actually see plasma and you pour it, it pours like water. But if you get a lot of protein in the plasma, it'll actually thicken the plasma. So instead of pouring like water, it actually starts to pour like maple syrup. It becomes very thick and viscous. So a small percentage, it's really small nowadays with modern technology, not more than 5% of patients will develop thickening of their blood due to the high protein level produced by the weeds that causes the blood to move sluggishly as it thickens. And as the blood drags through the blood vessels, it can cause those blood vessels to tear. And so when people develop a lot of protein in the blood and the blood thickens and becomes more viscous, it can cause problems with nosebleeds that don't quit. And I've seen a dozen patients over the years who presented to the emergency room with nosebleed, got cauterized, went home, back in the ER 2 days later, got cauterized, back home. 2 days later, nosebleed. Someone does a blood count, finds they're anemic, and then that kicks off the investigation. Nosebleeds aren't so bad, but one of the issues that may occur, fortunately very rarely, is that thick blood can tear the blood vessels in the retina and cause retinal bleeding. I don't know how many of you have been sent to see the eye doctor by your specialist, but it's something in people who have high protein levels. They have to be pretty high. Low proteins, this isn't a risk. But with high protein levels, I want to hear from the eye doctor to be sure that there aren't any torn blood vessels in the retina causing bleeding problems that can lead to permanent visual loss, which is kind of a semi-urgent. Most interventions for this disease aren't very urgent because this comes on slow. This is a slow-growing weed, and most people kind of evolve into having problems. Occasional patients present with severe anemia, but that isn't typical. It just kind of little by little, but sometimes you can get bleeding in the eye, and that can be a problem. I want to talk about a more common problem, though, more pictures. We are now looking at an electrical wire. And an electrical wire has two parts: the wire and the insulation. And for wires to work, you need both. The wire needs to be functional. It has to be there to conduct the electrical current. But if you have a naked wire with no insulation, you do not have a functioning wire because it's going to short out like that. You've got to have insulation around the wire. And the nerves in your body, particularly the nerves in your feet, ankles, calves, they are electrical wires that have insulation and the wire itself. And there are very specific disorders that can damage different parts of the wire. The wire itself, which in medical lingo is the nerve axon, axonal, can be damaged very specifically. I'd say the most common things: lead will kill the wire, polio kills the wire, diabetes kills the wire. But the insulation is just as important. And unfortunately, for some people, I'd say maybe 10% of patients, that IgM protein, for some reason, is sticky to that insulation. It sticks onto the insulation, and as a consequence, damages the insulation, and that damage to the insulation leads to the wire to short out. So the insulation in medical lingo is the myelin sheath. It's insulation. It's a fatty membrane that protects the wiring. And when that myelin sheath is damaged, we refer to that as a demyelinating neuropathy. And unfortunately, maybe 1 in 10 patients with IgM proteins, that IgM will bind and damage that insulation, stripping it away so the nerve starts to die. And usually the way in which this goes is the damage is at the nerve tip. And the longer the nerve, the more predisposed the wire is to being damaged. And the longest nerves in your body are the nerves that run from your low back to the tips of your toes. Those are the longest nerves. So they're the ones that are most likely to be affected. And so as this starts, people start to feel toe numbness. And as it progresses, it starts moving up the wire. It becomes soles of your feet, instep, ankle, and it begins to move up. Typically, this is a process that will evolve over 10 to 20 years. It really, for most patients, is quite slow, but if it gets bad enough, it can be debilitating, because although it starts just with the nerves that give you your feeling, you have it long enough and it starts to cause the motor nerves, the ones that control your muscles, to get weak. And so all of a sudden, your foot can get floppy and it's a little hard and you're at risk of tripping because your toe drags on the carpeting. The second piece of it is that as it goes up, then you're going to start having problems rising from a chair as you start to get weakening in your calves and weakening in your thighs. And the sad part of this is that this has nothing to do with how many weeds there are. This is a chemical reaction between the protein and the nerve, and it can occur with extremely small levels of the abnormal protein. And in some people who get this nerve damage, wire damage, this can occur with very, very few weeds in the garden and with very low levels of protein, but it's still just as disabling and does require intervention, simply because this can cause very significant impairment in your activities of daily living and your quality of life. Let's talk briefly about weed killer. There are really two large classes of weed killer. Probably the older of these two, which dates back, I'd say, between 15 and 20 years, is chemoimmunotherapy. Immunotherapy really means antibody therapy, antibodies that kill the weeds. The most common of these would be rituximab, or trade name Rituxan, but it's generic now, so rituximab is the preferred, and it binds and it will kill the weeds, and I'd say you get about a 50% reduction in the weed count in about 40 to 45% of patients. And then the chemotherapy comes in a couple of different flavors. I would say the most common is bendamustine. So rituximab and bendamustine. And you heard just before me, our patient representative from UK, Australia, received rituximab bendamustine and has been in remission for well over 10 years, which frankly is not an unusual event with rituximab and bendamustine. Bendamustine is given intravenously, a bit of a drawback. Usually given 4 to 6 months. We heard 8 months, but 4 to 6 is a bit more typical. But the actual optimal duration of therapy, how long should you be on chemoimmunotherapy, really should be, I think, individualized for each patient. Since we're able to measure the level of the protein with each cycle of treatment, we can monitor it as it comes down, and we can determine if the protein's still coming down, then I would be inclined to continue treatment. But if the protein has already reached its maximum decline and it's not going down any further, I'm really quite comfortable with stopping the treatment. And so the duration of therapy, I think, can be customized a bit based on our measurements of what the protein's doing. Because if it stopped going down, another 3 treatments is not going to make it go down any further. So that's chemoimmunotherapy. A second-line therapy, it predates bendamustine, is a drug called cyclophosphamide. It works in a very similar fashion, produces a similar response rate, but it causes more nausea, vomiting, hair loss. So it's a little bit more toxic, but all of these side effects tend to be fully reversible. And then the second class of agents are the BTK inhibitors. The first in its class was ibrutinib, which you might know by the trade name Imbruvica, which is an oral agent that can be taken on a daily basis to kill the weeds. And its cousin, zanubrutinib, which I think is called Brukinza, which is also an oral agent that's used to kill the weeds. These two classes of chemoimmunotherapy and BTK inhibition is in my practice anyway, an area of shared decision-making with patients. Because the two agents produce really quite similar response rates and benefits, and very, very similar duration of benefit. Not only how far will the protein go down, but how long will it stay down are important considerations. And chemoimmunotherapy and BTK inhibitors, Imbruvica, Brukinza, are pretty similar. There are small differences depending on the study, but they're similar. So what are the distinguishing features that I discuss with my patients? Well, bendamustine is intravenous, and the BTK inhibitors are pills. And so for some patients, their preference is, you know what? Yeah, I don't want to start with intravenous and injections and coming in. I'd much prefer to have pill therapy. But the flip side is that chemoimmunotherapy is fixed duration. Usually 4 to 6 months, you heard 8 months, but still fixed duration treatment, where oral BTK inhibitors, the Imbruvica, Brukinza, those are really designed for indefinite use. At this point in time, it's not typically designed to give a finite period of time. The general understanding currently is as long as it's helping and you're not having much in the way of side effects, we'll talk about that in a minute, stay with it. So what are the side effects of the treatment? Well, chemoimmunotherapy is actually pretty well tolerated, particularly if it's bendamustine, because the primary side effect is on the blood count. So when we're giving weed killer, we have to be careful with how much weed killer we're giving. Because if you have a garden out back and you've got weeds and you apply weed killer and you give, I don't know, you put a teaspoon of liquid weed killer in a gallon garden sprayer and you spray the garden and the weeds are thinned out nicely, you don't say, oh, that teaspoon worked great. I'm going to put a cup in next time. And you don't do that because you know that the weed killer you use in your garden is not all that selective. And if you give too much weed killer, you end up killing the garden. And that's not what you want. You want a healthy garden. Chemotherapy is much the same way. It requires careful monitoring and a specialist who understands how much weed killer is the right amount of weed killer for a 50-year-old versus an 80-year-old, for someone who's runs triathlons and someone who's had 2 open heart surgeries, to do the dosage adjustment so you hit that sweet spot to kill as many weeds as you can without killing too many of the healthy garden plants. And so when you're receiving this weed killer, it's very common. Your provider saying, you need to come in once a week while you're on treatment so I can check your blood count. And the purpose of that weekly checking of the blood count is to be sure we're not overshooting the mark and giving too much weed killer that's causing damage to the healthy garden plants, which will reduce the red count, the white count, and the platelet count to levels that are unsafe. But those are all generally reversible, and they usually go away very quickly. With the oral BTK inhibitors, the 3 major side effects are diarrhea, which can be a real problem, bruising, and irregular rapid heartbeat. Those are the 3 big things that we watch for. Some people, it raises their blood pressure as well, but generally speaking, we can control that with blood pressure medication. But those are the 2 big classes. Where we are right now is looking at other agents and other combinations to manage these weeds. I would say after chemoimmunotherapy, whether it's bendamustine or cyclophosphamide, or after BTK inhibitors such as Brukinsa or ibrutinib, would be venetoclax or Venclexa. So Venclexa venetoclax is an oral agent that kills weeds that express a protein on the surface called BCL2. Not important. But it was found to be very active in the treatment of leukemia, was subsequently tested in patients with macroglobulinemia and found to be a highly effective. So now we have 3 major lines of therapy that are effective for what is a slow-growing disease that can be given for fixed duration orally with very, very good. And a lot of the research that's going on is, well, can you add this venetoclax, this Venclexa, to bendamustine? Can you add it to zanubrutinib or Brukinsa? And so those types of combinations are being explored. But I think what you heard at the panel is not unusual. It's very common for patients to receive rituximab and bendamustine and have a response longer than 10 years. I think 18 years? Is that? I mean, long response durations. And although that doesn't always mean cured, the term functional cure does apply to some patients because they're not on treatment and there's been no disease activity for 10 or 15 years. And again, I'm not sure my goal is cure, but if you have disease control without treatment that's long-lasting, and you live long enough to die of a completely unrelated disorder that is not connected to macroglobulinemia, I'd say that's a fair application of the term functional cure. And I do think that that is within reach for our patients. I wanted to leave some time for questions, if I may, because I'm not going to be available for the Q&A panel, which is occurring in a day or two. And I was wondering, would it be okay to take some questions? So, with that little primer on the garden, which the IWMF website has my videos dating back to when I was a pup. To review this, I think I'd like to take some questions about anything that might have been unclear. So we can just start and you ask your question. And there's a hand. Yeah, we're good.
I have a question. You were talking about the IgM and the weeds. So does it matter what your level of IgM is in terms of the weed? So for example, mine was 571, but I was highly symptomatic. So how does that relate to how much?
Right. So there's a very poor correlation between the level of the IgM and the number of weeds. Some weeds make very, very little IgM. The garden is severely damaged and compromised, but the IgM level is minimal. That's determined by how much IgM is made by each weed. And that's something that is variable from patient to patient, which is why you can't compare IgM numbers. There are patients who make exuberant amounts of IgM, but have very, very few weeds in their garden. That's why it is naive for a provider to say, well, we're going to watch you, but if your IgM is 3,000 or 4,000 or 5,000 or 6,000, we're going to treat you. Treatment is never determined by the level of the IgM. Never. It's determined by symptoms. Now, admittedly, the higher the IgM, the more likely you are, but I had an individual who was a public speaker who lived in San Diego, and at 10,000, I was still watching him with a 10,000 IgM. Even I was surprised, but I did all the necessary testing, and he was completely asymptomatic with his 10,000. Finally needed treatment when he had 12,000. But the level of the IgM is never a driver for intervention. We measure things, obviously, eye exam, the thickness of the blood, those are all very important to be sure you're not at risk. And the testing that you need to do to be sure it's safe to continue observation it's quite a bit more that you have to do to be sure it's safe to say do nothing. But again, the IgM itself, and some people can develop serious complications like the nerve damage has nothing to do with the IgM level. Earlier, cold agglutinin disease was mentioned. That's an anemia associated with IgM, also unrelated to the IgM level. So you can have patients who are living the dream, doing great with their 4,500 IgM, and people in desperate need of therapy with an IgM of 600. Now, your IgM, as it changes over time, is important. But again, talking to the person next to you and asking what their IgM level is, it just doesn't provide any insight as to what is the severity, because that's locked into the weed as to how much IgM it produces. That was a very insightful question. Thank you. Any other questions? Go.
I understand the effect of the IgM, and my question was, what are the outside causes of it?
Are you asking me what
Of the
causes
weed.
macroglobulinemia?
Yes.
Oh, no, I don't know that. But I don't know the cause of high blood pressure. I don't know the cause of why some people get degenerative arthritis of their hips and knees. I don't know why you get colon cancer. The only thing I know is you smoke, you get lung cancer. That part I know.
Okay.
But in terms of all the other cancers, I mean, actually what causes breast cancer, what causes stomach and pancreatic cancer, that remains unknown. Now, we do know, of course, that there are certain damages to the DNA of these cells And of course, you know the gene, it's MYD88. And if that gene gets damaged, that's kind of characteristic of a Waldenström cell. And again, that gene abnormality, that genetic change, to be distinguished from an inherited change. It's not inherited, it's part of the weed. But how did that weed get that MYD88 mutation? What led to the DNA damage that led to the change in that gene that predisposed you to macroglobulinemia? That still remains an important aspect of research. But if I knew why you got it, I'd be able to tell the rest of the population what they need to do not to get it, and I don't.
Hi, do you do any specific exam or testing for the neuropathy, or do you just follow it clinically? And how do you change your treatment if a patient is suffering specifically with neuropathy?
Some centers will do routine needle electrical testing of the feet to kind of get an objective measure. I'm pretty old school, and I like asking people if they can feel their feet and if they can feel their toes and if the numbness is getting worse or is the level of sensory loss climbing over time. Now, typically we'll collaborate with a neurologist, and they almost always will insist on those measurements. But patients are very reliable reporters of their own sensory loss, and I can use that. So if someone has no numbness, I'm certainly not doing the test to screen for it, because if it's not bothering them, I'm actually not looking for new stuff to do. Treatment is quite controversial because the treatment is not all that great. It's not super effective. If it was, we initiate it on every patient with symptoms, but people with very mild symptoms, we don't. I would say a lot of it depends on whom you see. I think neurologists like to use a lot of intravenous immunoglobulin to try and treat the neuropathy. And just because I'm a chemotherapy kind of guy, I will use treatment for Waldenström. I'll use rituximab typically to try and improve the neuropathy. But there are reports where bendamustine helps it, and Imbruvica helps it, and zanubrutinib, Brukinza helps it, bendamustine helps it, and so, but that's usually driven by the degree of impairment. Most people early on don't have much impairment. They have the numbness, but they don't have pain, they don't have motor weakness, and so I don't feel a requirement to institute therapy if it's more of a nuisance symptom rather than a symptom that's beginning to interfere with function or activities of daily living.
Thank you. So you mentioned two kinds of sequelae. It sounds like we're talking about neuropathy and retinopathy. Are there other organ systems that can be affected? I'm thinking in particular renal dysfunction.
Yeah, that's a fair. There are patients with macroglobulinemia that can develop kidney problems related to it, and there's a bunch of different ways. One, the actual cells, these weeds, these lymphoplasmacytic cells, are capable of directly invading the kidney as a mass, causing the kidney to operate less efficiently, but also the IgM protein can trigger inflammation within the kidney, technical term glomerulitis, glomerulonephritis, that can cause the kidney to be inflamed, leak protein, cause high blood pressure changes. That can occur. And 7% of patients with IgM protein can deposit another protein called amyloid into the kidney that can cause it to leak protein. So I didn't mention it simply because it's compared to the eye damage and the nerve damage, it's much less common, but there's no way this is such a unique disorder. We're not going to be able to cover every clinical manifestation of it, but absolutely the kidney can be affected. And when it is affected, it treatment is mandatory. Usually, preservation of kidney function is so important that if the kidney is showing some problems, we're not saying, oh, you're feeling good though, and you're not having any swelling, we're just going to watch it, because the problem with the kidney is before you start developing symptoms, you lose 90% of your function before you start feeling anything. That's unacceptable, and the kidneys you've got, that's what you've got. They've got to last you the whole distance. And so when we see any compromise of the kidney, even if you have no symptoms at all, it's intervention time.
Okay, I have two questions. One is WM hereditary? And the second one was, you talked about these combinations. At what point do you do those combinations?
So is macroglobulinemia hereditary? There's certainly a subset of about 10% of patients where there is a clear-cut family history in first-degree relatives. I had one family from about 40 miles west of where I work where I took care of the mom with macroglobulinemia, then I took care of her daughter with macroglobulinemia, and her brother had an IgM monoclonal gammopathy. That's not a coincidence, okay? In 90% of patients, there is absolutely no linkage, but you can get a history that can't possibly be random in 10% of patients. But it's not one of these single gene type of inheritance patterns like sickle cell disease or Huntington's disease. It's a multigenic problem that still hasn't been sorted. Mary McMaster was a long time member of IWMF at NCI whose entire career was on familial macroglobulinemia. So it does exist as an entity, but because 90% of patients don't have that, my practice is not to recommend protein screening of the blood in first-degree family members. The second is combination therapy. In this disease, which is slow growing, where treatment can be highly effective and very durable responses, just because we have a new medication doesn't mean we automatically add it to the old medicine on the assumption it will work better. That requires proof, where you actually have half the patients take both medicine, the combination, and the other group take one medicine and actually prove that it's better. There have been a whole host of combination therapies reported in the last few years. One was ibrutinib and venetoclax. The trial was terminated early because of early cardiac death in the two-drug group. Hard to know if that was related or not, but it certainly led to suspension of the trial. A drug called bortezomib or Velcade, maybe a small percentage of patients might have received that, has been combined with bendamustine. I'm not impressed that that produces higher response rates. So it really requires active research to determine if combinations are better than what we currently have. So those are in flux and fluid, and it changes over time. And so I'm here today saying, I don't know that combinations are ready for prime time now, and in 3 years that could be completely the wrong answer.
Can you explain the connection, if there is one, between an anti-MAG diagnosis with Waldenström?
Right. So when I talk about the protein damaging the fatty sheath of the nerve, causing the insulation to be damaged, I said that insulation is called myelin. MAG is myelin-associated glycoprotein. And one of the markers that we use to say that your numbness is related to the macroglobulinemia is the finding of high levels of this anti-MAG antibody in the blood. And so typically before I conclude that nerve damage is from macroglobulinemia, I like to see evidence of the damage to the insulation, and that damage shows up in the blood as an anti-MAG antibody. So that's part of the diagnostic evaluation of the patient who has nerve damage. Am I done? One more. One more.
It might be too long. I'm sorry. Any clue why the weeds sometimes leave the garden and find homes elsewhere?
So that's a really important thing because most of these weeds require the soil of the bone marrow to grow. And they won't. You try to take these cells and put them in culture in a laboratory, you can't do it. They die. They require very special techniques to keep them alive. That soil does exist in the liver, spleen, and lymph nodes, but some patients will develop tumors outside of those. And what characterizes those ability to grow outside of that garden soil is not well understood, but is generally considered an adverse event. It's considered a serious complication where all of a sudden the weeds are growing where there's no soil.